Next, Dr. Disha Agarwal. I would like to request Dr. Shusha Sugathan to be ready to be the next speaker.
And all, I'll be presenting on clinical spectrum and recovery patterns in patients with acquired isolated ocular motor nerve palsies. As we all know, we need an intact motor and sensory system for a perfect binocular single vision. In the motor system, the third, fourth, and sixth cranial nerves play the important role by supplying the various extraocular muscles for a perfect coordination. Lesions in any of these nerves or their pathway causes what is known as paralytic strabismus. Various etiologies have been identified for the same in various study populations. In the most extensive report from the Mayo Clinic that included 4,278 cases over 30 years, sixth nerve palsy and idiopathic cause was identified as the most common. However, different studies have found different results because of the different study population included. Also, the time taken to recover and the degree of recovery depends on the nerve involved and the etiology. We need to know what is the most common etiology and the nerve involved in our study population, as ocular motor nerve palsy is a very common entity presenting in ocular emergency. So the aim of our study was to determine the different etiologies and recovery patterns in the patients with acquired isolated OMNPs and the association between them in our study population. The study was a prospective observational single-centered study done from July 2021 to June 2023 at JIPMER Pondicherry. Consecutive sampling was done after approval from Institutional Ethics Committee. We included all patients above 5 years of age with acquired isolated OMNPs and excluded patients with congenital OMNPs, combined OMNPs, terminally ill patients, patients who were previously diagnosed with strabismus, patients with known restrictive disorders, and patients who had visual acuity less than 660 for which diplopia charting and Hess charting could not be done. After collecting the demographic data and detailed ocular and systemic history, we did standardized eye examination and detailed squint evaluation, which included ocular motility assessment, diplopia charting and Hess charting, and quantification using the PBCT and modified Krimsky test. Torsage measurement and pupillary examination was done, and baseline RBS and BP was checked for all the patients. Neuroimaging was done wherever indicated. Etiologies were classified on the basis of ischemic, compressive, traumatic, iatrogenic, and idiopathic, and recovery patterns were classified as complete recovery, partial recovery, some recovery, and no recovery. This is the clinical picture of one of our patients with right sixth nerve palsy, which was of ischemic etiology. We can see restriction in lateral gazes and diplopia charting for a patient with right sixth nerve palsy and Hess charting. This is a clinical picture of a patient with left-sided third nerve palsy and Hess charting for a patient with traumatic left third nerve palsy, and diplopia charting for a patient with fourth nerve palsy. Statistical analysis was done using IBM SPSS version 19. Categorical variables were represented as frequency and percentages, and continuous variables as median. Kruskal-Wallis test and Fisher's exact test were used for analysis. Coming to the results, we included total 80 number of patients, out of which the maximum were of the sixth nerve palsy group, that is 68.8% patients. Median age was 47 years. We had an equal representation of both female and male gender, and we had more of unilateral patients. Coming to the etiologies, there were more of ischemic patients in our study population, that is 35%, closely followed by idiopathic, traumatic, compressive, and iatrogenic, which was only one case, that was of third nerve palsy. Among the various etiologies in various nerve palsy groups, sixth nerve palsy had maximum ischemic palsy patients, and third nerve had maximum traumatic cases. Fourth nerve had both ischemic and traumatic equal number cases. Among the third nerve palsy patients, maximum patients were having pupil involving palsies, that was 61.1%. All the ischemic cases had pupil sparing palsies. All iatrogenic and compressive cases had pupil involving palsies. This difference was statistically significant. At the end of month 3, we had 53.8% patients with complete recovery, out of which maximum belonged to the sixth nerve group, that is 69.1% patients. This difference was again statistically significant. Similarly, at the end of month 6, we had 86.3 patients with complete recovery, out of which 94.5 patients belong to the 6th nerve group. Again, this was statistically significant. Dividing the recovery pattern on the basis of etiology, maximum recovery was shown by ischemic palsy patients, that was 39.1% patients. This was again statistically significant. It is important to note that we had no patients with no recovery by the end of month 3, which tells us that acquired isolated OMNPs had very good prognosis. Conclusion, so our study showed that the most common acquired OMNP was 6th nerve palsy, least common 4th nerve, most common cause was ischemic, and earliest to recover was 6th nerve palsy and palsies of ischemic etiology.
So very nice study. How do you differentiate between some recovery and partial recovery?
So ma'am, we decided the criteria that if a patient is having, the partial recovery was defined as having some residual strabismus, which will be of prism diopter less than 10 prism diopters, and complete recovery will be 0 prism diopters. So anything between that will be some recovery.
I didn't get it. So could you repeat that again?
Sir, complete recovery will be the patients who have no diplopia at the end of like month, the follow-ups were done at month 3 and month 6. So complete recovery will be there should be no diplopia, and there should be no deviation on PBCT as well. Partial recovery was that the PBCT at the end of at the follow-up visit should be less than 10 prism diopters. So anything between 10 prism diopter and the baseline prism diopter was considered as some recovery.
Thank you.
Thank you, ma'am.